clinic at Johns Hopkins and work with Doctors Harris and Ng on researching different disorders within this group. We were supposed to go earlier today, so my initial slides are a little bit kind of trying to explain some of the things you've already heard about, but maybe it'll sort of bring it all together. So I'll go ahead and get started. So we'll be talking about overlapping cognitive and behavioral, and I'll add genetic features across KAT6A and KAT6B disorders. So our objectives for today my objective for today is to give an overview of KAT6A and KAT6B syndromes with both genetics and epigenetics perspectives. So the Mendelian disorders of the epigenetic machinery, or another term for this is chromatinopathies, are a group of genetic disorders that result from germline pathogenic variants in epigenetic machinery genes. And KAT6A and 6B are within this group of disorders. So these disorders are divided based on whether their job is to write or place epigenetic marks, erase or remove epigenetic marks, read or interpret epigenetic marks, or remodel chromatin. And both KAT6A and 6B, which you've seen a lot today, are actually writers, or they place these marks. And they also function as readers that interpret the marks as well. And these are autosomal dominant conditions, which we'll talk a little bit more about what that means. And the clinical features in this group as a whole, the main ones are intellectual disability and growth abnormalities, as well as other tissue diverse manifestations. And I'm going to talk to you about how these disorders are genetic disorders with epigenomic consequences. So just to kind of go over some basics, and hopefully this will kind of put everything you've heard today into perspective. So our bodies are made up of billions of cells, and each cell contains genetic material in the form of DNA. The DNA contains about 22,000 genes, and each gene determines specific traits. And then each gene is a set of instructions or code to make a protein with a specific function. And the DNA code is made up of these 4 bases. And then the term genetics just mainly refers to the DNA code. Genetic variants or mutations are mistakes in the DNA code that cause disease. And what the sort of intermediate step then is the genes encode proteins that have particular functions in the cells of the body. So the KAT6A gene encodes the KAT6A protein, and the KAT6B gene encodes the KAT6B protein, and those proteins have particular functions in the body. Pathogenic variants or mutations in KAT6A, as you know, cause Arboleda-Tham syndrome, and those in KAT6B cause kind of a spectrum of conditions that were previously named genitopatellar syndrome and Say-Barber-Biesecker-Young-Simpson syndrome. So I mentioned that these are autosomal dominant conditions, and so what this means is that only one copy of the gene is affected in each condition, so one copy is functioning normally. And we've heard a lot about the different types of genetic variants and their effects on protein throughout the day. And so I just kind of wanted to kind of take a minute to explain what this means on a more general, global terms. So in the normal situation, the DNA has the expected sequence and the proteins are functioning properly. There can be missense changes, which are like spelling errors in the genes, and that can cause the protein to have an altered function. And we've talked a lot about protein truncating variants and whether they occur early or late. And these are different than missense variants because they can lead to, if they occur early, no protein being produced, or if they occur later, there could be an abnormal function for the protein or something like a dominant negative effect where it could poison the normal copy. So what do the KAT6A and KAT6B genes do? What do their proteins do in the body? So this is just a schematic of our genetic material. So the genetic material is divided into functional units called genes. But the DNA does not exist alone in cells. It's wrapped around these proteins called histones. And it's the histones and the DNA together that are called the chromatin, which we've been talking a lot about today. And so KAT6A and B switch genes on in cells by adding a chemical group called acetylation, and this can occur on the histone proteins. So what this is illustrating is just that if you have the acetylation mark, the chromatin is more open and the genes can be turned on, whereas if that mark is not present, then the chromatin is more closed and the genes are turned off. And so it switches on and off genes in cells. And when there are mutations in these genes, then we, and what a lot of people have been talking about today is that we think that part of how these syndromes occur is that these proteins that can no longer place this acetylation mark properly, you kind of have a change in the levels of this mark that can lead to differences in how the chromatin looks, whether it's more open or closed, and whether the genes associated are turned on or off. But it's not as simple as that. It's not just they place this one mark and this one mark determines whether a gene is turned on or off. There are many, many, many marks in the cells. There are many, many, many genes in the cells. And so it's much more complicated than that. And I think we've heard a lot about that from all the researchers that are doing such great work. But just to illustrate what we mean and why it's so complicated, why it takes so long to do these studies, is that so in the normal situation, you have certain genes like gene 1, which are expressed, and other genes like gene 2, which are silenced or turned off. And at genes like gene 1, you have these writers of these activating marks like KAT6A and 6B. You have erasers of silencing marks, readers of these marks, and remodelers of these marks. And the net effect is this open chromatin structure and a gene that's expressed. At other genes, like gene 2, you have writers of silencing marks, erasers of activating marks, and readers of these marks with the net effect of a closed chromatin state and genes like gene 2 being silenced. But when you have a disorder like KAT6A or 6B or one of these other disorders within this big group, then you can see these differences result. So if you can't have this writer placing its activating mark at gene 1, then you don't have the activating marks placed, and you have this abnormal closed chromatin structure and abnormal gene silencing. But that's the direct effect. There are also many indirect effects that occur throughout the cells. So if the silencing machinery can no longer silence genes that are supposed to be turned off, then those genes can get abnormally turned on kind of indirectly. And so you can see that there can be genes that are abnormally turned on and off with different chromatin states kind of throughout the cell and causing these broad epigenomic changes. And that's why it's it's really complicated to kind of figure out what's going on. And other things that we've learned today are that, that we're all very interested in therapies that might treat these disorders. And so one possibility might be to sort of, if you have one of these syndromes and your sort of chromatin is abnormally closed in certain areas and open in others, you could potentially restore that balance using an epigenetic therapy that could kind of restore that balance. And so then what is it that, why does this matter? And this matters because individuals that have these gene mutations, which affect their proteins, which place these epigenetic marks, have these features that we all know very well. So the neurobehavioral findings, which Dr. Harris and Eng will talk about, the eye findings that many of the children and adults have, craniosynostosis, characteristic facial features, the GI findings, the congenital heart defects, frequent infections, sleep disturbances, and growth abnormalities for KAT6A. And then for KAT6B, there are a lot of overlapping features, so they can have the developmental delay and intellectual disability, the low muscle tone, congenital heart defects, the hypoplastic, which means small or absent patella of the knee, thyroid abnormalities, hearing loss, dental anomalies, some genitourinary anomalies, as well as other features that kind of differ between the two disorders. And so just kind of wanted to give more of a broad overview of kind of what we think is going on from the genetic mutation to what we see in patients with these disorders. And then the way that we manage these individuals are to make sure they're in the appropriate developmental therapies, screen for things like the congenital heart defects and eye problems, symptomatic treatment for GI manifestations, sleep studies if there's any concerns about obstructive sleep apnea, abdominal ultrasounds, in some cases, brain MRIs and audiology evaluations. So that's, and then in some cases, we would consider immune workup if there's a concern for recurrent infections. So that's sort of the end of my part of the presentation, and now I will turn it over to Dr. Harris.
Hi, I am Dr. Jackie Harris, and I am a neurologist and neurodevelopmental specialist who studies epigenetic conditions like KAT6A, KAT6B, and I'm going to go a little more clinically in depth as to what we see from a neurologic and neurodevelopmental perspective, and then we're going to move to some of our research and what we have more of an understanding about the specific cognitive phenotype of these disorders. So, starting with the actual structure of the brain, we do hear about and think about brain malformations in KAT6A and KAT6B syndromes. And for KAT6A, there have been many, many minor brain malformations reported. However, most of these are just kind of secondary findings. Yes, we believe they are related to the KAT6A, but we don't believe that they tell us a whole lot about what the underlying phenotype or presentation, the symptoms of the person is going to be. About 1/3, give or take, of individuals with KAT6A have microcephaly or a small head, and thin or absent corpus callosum reported. Many more things, but this talk is actually going to focus on the things that overlap between KAT6A and KAT6B syndromes. KAT6B, in contrast, the majority have agenesis of the corpus callosum or some other kind of corpus callosal abnormality, and close to half of these individuals have microcephaly or a small head. And so these are two things that seem to overlap. Again, as a neurologist and who thinks about these epigenetic syndromes all the time, I don't really put much stock in the MRIs. So whether or not you do or don't have a corpus callosum, whether or not you do or don't have a big head, doesn't really change how I think about the neurologic or neurodevelopmental phenotype of the individual all that much, because either way, it's still caused by the KAT6A or KAT6B syndrome. And so that's going to be the overarching thing that's going to determine how I give you prognostic information, not based on the brain MRI. Hypotonia. So hypotonia means low muscle tone. So kids can be described as floppy or very, very flexible, or, as the kids get older and they have a little bit more gross motor skills, but they still have the low muscle tone. Oftentimes this can be described as clumsy. Hypotonia is reported in the majority of patients with KAT6A and KAT6B syndrome. And honestly, if you look at the literature is really great at reporting and talking about some things, but these very specific neurodevelopmental, cognitive, neurologic features are not always that well reported in papers that are really designed to talk about other things. And so we think that most likely, even the ones who aren't reported, if I or another neurologist examine them, they probably too have some degree of hypotonia, whether or not it's severe. And so I'd say this is a nearly universal feature in KAT6A and KAT6B. Hypotonia, it's very important to note, anybody who's ever seen me clinically has heard me talk about it. It's centrally mediated. It comes from your brain sending signals to your muscles. So it doesn't have anything to do with strength. Most of you, know that your kids are probably plenty strong when they want to be, right? It has more to do with kind of that resting signal from the brain to the muscles and how tight the muscles stay based on that signal. This can be very, very significant, especially in infancy in kids with KAT6A, KAT6B, described as floppy babies. And it's pretty much always still present, but generally not as significantly impairing later in life. Although, families do report that the kids are clumsy, have poor balance, but most of the kids are functional motorically. Not all, but many. Physical therapy is definitely necessary early on to help get over those threshold functions and maybe beneficial later too, but this is child and therapist dependent and even time dependent. Seizures. Get lots of questions about seizures. It is more common than the general population in both KAT6A and KAT6B disorders, but it is still not a common feature of either. So, for both disorders at present, from what we know, the majority of patients with KAT6A and the majority of patients with KAT6B do not have epilepsy, but certainly it is. Kids with KAT6A or KAT6B and adults are more at risk for seizures than those who don't have a syndrome. There have been multiple seizure types reported for both, and we don't have any consistent recommendations yet. We just don't have enough data. So we don't know, what do EEGs typically look like? What is the most common seizure type or time of seizure onset, or which medicines work better than others? We don't know that yet. So we just treat seizures in these conditions like we would treat seizures in any other case. And then neurodevelopmental issues are generally the primary concern of families, especially after infancy. And this is the primary area where our research and clinical care is focused. And so I'm just going to talk briefly about early development and behavioral issues, and then I'm going to turn it over to Dr. Eng, who's going to talk much more in depth about this subject. So, early developmental milestones are generally universally delayed. Gross motor often catches up a bit more, but things like walking can be quite delayed. Fine motor usually is a pretty big difficulty throughout life. Social emotional skills can sometimes be a strength, although there are certainly difficulties associated with difficulties with communication and sensory issues, other things. Language we're going to discuss a little more later. Uh, Children with KAT6A and B often look more delayed in early childhood than later on, because that low muscle tone really impairs what we can test and see. And so early engagement with therapies through infants and toddlers or any other mechanism is important. Behavioral issues, about a half or a little more of individuals with KAT6A and KAT6B syndromes report some sort of behavioral issues. Things can include autism, ADHD, sensory processing issues. And again, right now, from what we know, although we hope to develop more knowledge with more specific recommendations, treatment plans for these behavioral issues should look like the treatment plans for these issues in other syndromes or non syndromic kids. So, individuals with ADHD should be treated like ADHD, etc. Um, and so, with that, I'm going to turn it over to Dr. Eng, who's going to talk a little bit more about cognition and our research.
So I'll be talking a little bit more about the cognitive phenotype associated with KAT6A, KAT6B disorders, but also some of our preliminary findings from our last data collection. So some of you might remember last year we had some data collection with KAT6B disorders, the previous year with KAT6A syndrome. So just generally, thinking about KAT6A syndrome, the neurobehavioral kind of or neurocognitive phenotype of KAT6 disorders are generally kind of relatively unknown, although some more is known with KAT6A than B. KAT6A is associated with a global developmental delay. Studies that look at the retrospective kind of chart reviews generally tend to see more improvement, again, with like changes in motor skills than with language over time. Language seems to make slower progress and generally makes smaller increments in change over time. When we think about the different variants within KAT6A syndrome, generally appears that like those with early truncating or late truncating than earlier truncating seem to have worse delays, and both worse than missense variants. Intellectual disability is most commonly found in KAT6A syndrome. It's almost universally seen in individuals with their only up to date, I think, one person who might not have met intellectual disability diagnosis. Um, Again, we tend to see greater severity in intellectual impairment and adaptive difficulties. So to think about like life skills and independent life skills in individuals with late truncating variants. Most individuals with KAT6A syndrome fall in the moderate to severe range in intellectual disability. But when we think about intellectual disability, oftentimes the papers that are out there are not a really good description of the cognitive profiles because of the severe discrepancy that we know in verbal and nonverbal skills. So one of the very commonly known things about like KAT6A syndrome is that with a lot of the speech and expressive language challenges. And so when we think about like intellectual or measures, oftentimes it's kind of composite across verbal tasks, which requires verbal expression and also nonverbal skills. And so this kind of IQ might be a little bit skewed because of their kind of expressive language challenges. Again, like when we think about KAT6A syndrome, about over 70% are minimally verbal, so meaning that they might be using single words or signing, but not necessarily using phrase or kind of more sentence speech. There are no really known prospective studies using performance-based measures on language, but mostly on parent inventories and kind of more retrospective chart reviews. But it seems like based on what parent are reporting on language, both expressive and receptive language are equally affected. Um, Late trunking variants with KAT6A syndrome are usually or typically associated with more receptive language difficulties. So this is more like language comprehension, being able to follow commands, but less seen in less differences are seen in terms of expressive language. So being able to kind of use verbal or oral language. We also know that there's significant oral motor dysfunction that occurs in KAT6A syndrome, and this kind of dysfunction oftentimes then impact feeding, and this could happen across like different studies of 50% up to three-quarters of the samples. Again, we also see that late truncating variants seem to impact greater feeding difficulties or potentially oral motor skills. When we think about KAT6B disorders, we think there's much less done and known about this disorder. So we know that generally from case studies, from qualitative reviews, that there seems to be also significant expressive language and speech impairment, and also common occurrence is also again intellectual disability with greater proportion in SBBYS than the GPS disorders. But again, they're not very not a lot of literature based on performance data, so we don't really know if this is seen based on kind of more quantitative data or actual kind of performance-based data. Generally, there seems some case series seems to suggest that there are behavioral problems more reflective of like potentially autism spectrum disorder features, anxiety, aggression, and attention. But again, no really documented kind of like prospective data collection in KAT6B disorder. So much more understudied compared to KAT6A syndrome. So general takeaway so far is that, again, there's emergent evidence of some common impairment in language and speech, but more research is really necessary to determine how this might represent in terms of the intellectual impairment that we know of within the KAT6 disorders. Late truncating variants may be associated with poorer cognitive outcomes in KAT6A syndrome, and there's some emergent evidence suggesting that this particularly might also be seen in visual motor skills as well, which is a recent paper we came out. There's a high variability in phenotypic presentation. It seems like particularly in KAT6B disorders that we're seeing. And there are some emergent preclinical studies suggesting that there's potential for post-natal rescue of cognitive functioning, especially in animal models of epigenetic disorders. But more research is really necessary to understand this kind of the neurobehavioral phenotypes associated with these disorders, which can inform us of potential kind of behavioral outcome measures. So with this being said, knowing that KAT6B is much more understudied, much less data known. This data that we're presenting is kind of over encompasses our last data wave collection, which was all focused on KAT6B disorders, plus the previous year in comparison, which is our KAT6A syndrome. So we included 15 individuals with a confirmed diagnosis of KAT6A syndrome. About half males. All but one had a pathogenic or likely pathogenic variant. 2 early truncating, 10 late truncating, so most truncating variants, and 3 missense. And 12 out of the 15 were able to complete testing. Those who didn't were all truncating variants. So that's kind of something that we want to keep in mind. Again, like when we think about potentially how the different variants might be associated with different degree of cognitive challenges. For the KAT6B disorder group, we have 9 individuals that are confirmed with the diagnosis. All but one had a pathogenic variant, and 6 completed testing. So 3 were developmentally out of range for measures, meaning that they either were developmentally did not have the comprehension skills to understand the test measures to complete it. The tasks we used were really primarily focused on nonverbal cognition because we know from existing literature on how significant expressive language and verbal language may be impacted in KAT6 syndromes. And so we focused on that more particularly. We also included a visual motor, visual perceptual task, and a receptive kind of language measure, so a proxy for kind of language comprehension instead. Generally, what we're seeing is that so the gray bar here are all the KAT6B disorders. The white bars are the KAT6A syndrome, and as you can see, generally what we're seeing is that we're seeing nonverbal cognitions generally seems to be as affected as language comprehension overall. So like there does not seem to be that much more significant difference between nonverbal kind of reasoning skills as compared to language comprehension or ability to follow directions. And when we look across the syndromes, when we look across KAT6A and KAT6B syndromes or KAT6B disorders, they're performing very similarly across the board. So they were not seeing any group effects across all cognitive measures. When we think about kind of more day-to-day executive functioning skills, so executive functioning is kind of like organization, planning, impulse control, cognitive flexibility. We're seeing that parents are reporting generally not really significant clinical levels of executive dysfunction, so like that relatively low for individuals with intellectual disability, and again, similar degree of impact across both KAT6A and KAT6B disorders. And when we think about executive functioning, these are kind of cognitive functions typically in kind of prefrontal lobe. KAT6A and KAT6B disorders, when we look at neurobehavioral patterns, like what Dr. Harris has mentioned, knowing from the existing literature on KAT6A syndrome, we generally see that psychosocial functioning seems less affected, meaning that there's not a significant clinical degree as when we look at KAT6A syndrome as a group, even though individually we might see some kids who have more difficulties with emotional regulation and whatnot. But as a whole, when we look at 2 groups again, they're presenting very similarly in terms of internalizing, so thinking about more like anxiety, mood symptoms, and externalizing behaviors, so thinking about aggression and physical acting out kind of symptoms. And again, like the KAT6A literature, we're generally seeing that this area seems to be a relative strength, so that they're really reporting not much parents are really not reporting not much daily kind of aggressive behaviors, kind of internalizing behaviors. And the only really behaviors that we're really seeing a little bit more elevated, that seems more commonplace, is more attention difficulties. And again, this is equally affected across both groups as well. One of the common areas that we're kind of see a trend of across both KAT6A and KAT6B disorders is more elevated autism features. But they both seem to show a general trend of having a slightly better social affinity. So meaning that they might be like socially motivated to interact. They may not have the kind of technical skills in actually engaging or in maintaining interactions. We also see a lot more elevated kind of repetitive restrictive behavior. So being very sticky routines, sticky kind of thinking across both syndromes as well. But overall, when we look at autism features between the 2 groups, KAT6B disorders actually display more autism features than KAT6A syndrome generally, although across the board, they're showing very similar kind of patterns across the type of social difficulties they're showing. And again, thinking about life skills. So independent life skills are life skills thinking about like if you're able to kind of self-feed, kind of like dress, undress, kind of more kind of independence and kind of self-hygiene. These kind of overall life daily adaptive behaviors or life skills are similarly affected in both syndromes in kind of again what we would think of as the moderate to severely affected range, which is consistent with what we're thinking about like most common presentation for intellectual disability across both syndromes. Okay. So overall, what we're seeing is that nonverbal cognition and language comprehension are similarly equally affected in language in KAT6A and KAT6B disorders, and that generally we're not seeing a group effect, meaning that KAT6A and KAT6B disorders seem to show similar kind of neurocognitive presentation overall. These really support that ongoing occupational therapy and speech language therapy would be really essential at early childhood and ongoing for both syndromes or both disorders. Emergent findings also show that there's a shared cognitive phenotype across both disorders. And relative to other neurogenetic disorders, those with KAT6A and B disorders present with lower levels of behavioral problems. And when we think about this, even for individuals with general like speech language impairment, we often see higher rates of more behavioral regulation difficulties. KAT6 syndromes overall generally seems to have less kind of this presentation, despite in the context of their language difficulties. KAT6B disorder showed a little bit more elevated rate of autism features with slightly reduced social drive compared to KAT6A syndrome, although both show very similar kind of social phenotype from what parents are reporting. And from a clinical trial development standpoint, these findings kind of suggest that there might be benefits of shared treatments. So if the treatments for KAT6A syndrome might potentially also be effective for KAT6B disorders when we think about the impact on cognition. So some future directions. Again, we have a very small sample, right? So larger sample is really needed given that how small our sample sizes are, and for us to kind of make more also like detailed kind of genotype, phenotype kind of correlations. Particularly thinking about some of like the truncating variants as well. We need more kind of cross MDEM studies or cross kind of comparisons with other epigenetic disorders with kind of a shared kind of areas of epigenetic machinery being affected. And we also, one thing that we often see is that some of there's more elevated rates of visual impairment and hearing impairment in KAT6 syndromes. And so we really need more also adaptive neurocognitive tools for individuals with sensory differences. So for that, we can be able to capture these kind of cognition in spite of kind of visual or hearing differences as well. So we just want to acknowledge the KAT6 Foundation, who supported both the KAT6, both studies that we presented, the IDDRC and ICTRC for testing support, which some of you saw Laura and Kim and Laura and all our research group here. And this is the Multidisciplinary Epigenetics Clinic. So all of us, three of us are here. There's also Dr. Bjornson that many of you know, Jacqueline Britton, Carolyn Applegate, and also Felicia. So we just want to thank them for their help for scheduling. You might have seen them for some of our clinical visits too. So we're happy to answer any questions if any have any questions about the studies or generally about the two syndromes.
Thank you all. It's been part of our thought thank you all. I was curious when you said that you saw potential recovery and function in the mice. What were you doing in your mind to get the restore function? It was more than part of that mostly a rescue release. Meaning cancer, but just generally. Oh. Okay, so we don't have any mouse models of KAT6 disorders, just to be clear. So some people in our group have seen rescue of mouse models with other epigenetic disorders, so related with therapies for those mouse models. And then we know there are some groups who aren't here today, but like the Australian group has seen some rescue of mouse models with kind of a similar idea of epigenetic therapies, even in KAT6 disorders. Thank you. Another find out early or late.
You would just need to really look at the genetic test report and see where the mutation is. And if it's sort of in the last exon or the second to last, sometimes that would be a later truncating. And then anything before that would be earlier.
But only for KAT6.
But that's for KAT6A, just for KAT6A.
What about?
Well, I mean, it's the same. I don't know. It's not as distinct, I guess, as what it's not as distinctly kind of cut off for KAT6B, but I mean, generally when in genetics when we talk about like a later variant that might. So the reason it's important is because an earlier truncating variant is often degraded. The between the gene and the protein, there's an mRNA, and that gets degraded, and that's called nonsense mediated decay. So if it's earlier in the gene, then that just copy just kind of gets degraded and goes away if it's a truncating variant. But if it's in the end of the gene, at the last exon or sometimes the second to last exon, then that is thought that it may not get degraded and it may still make the protein, but with an abnormal function. And so that's the importance of it molecularly. But for for KAT6A, it's pretty defined. But you would just be a matter of looking at the genetic test result and seeing where the variant is.
Yeah, I think one of the key features when we think about schooling for children with epigenetic disorders like KAT6 generally is when if thinking about how flexible they are at adapting and providing more individual supports, right? Like, so every child is very different at presentation. Even though we say that there's a phenotype, every child's going to be different at the presentation individually for that phenotype. And so what's really important when we think about the school is more so if that they're adaptable to provide those individual kind of supports. So the level of kind of speech therapies, kind of having more one-to-one kind of like learning environment. If they're able to kind of provide kind of some sort of social skills training, occupational therapy, extended school year. And I think like the when we think about schools, oftentimes like, what families often ask, like, do you know what public school in this district that's better, right? There's no district that's ideally like that much better necessarily. It's more so like if individually within school districts, individually as a school, how much can they provide that kind of individualized support, I would say is the most important. With Montessori schools, I think that gets a little challenging for kids with developmental disabilities because it's kind of staggered learning in terms of like your child expected to take a leadership role for another child. And so with children with more cognitive difficulties, I think that it becomes really challenging because they get kind of put into groups that they're not making much kind of movement, as opposed to having more supportive scaffolding in an individual in either like a private or a public school system.
Um, And the other thing in regards to that question is, that may be a little bit different than maybe what we previously thought is that our data, and granted all the caveats that Dr. Eng was saying exist. We need more sample size, we need more testable sample size, all of those things. We're doing this again this year with some better measures, all of that, we'll get some better data to tell you, but our preliminary data seems to indicate that some of the previous dogma, which was thinking that in all the cat, at least the KAT6A kiddos, that it's really language that's affected and cognition or problem solving skills and things are relatively preserved, that in a lot of these kids that's not entirely the case, that their cognition, that their problem solving skills are impacted as well. And so it's important that we know that, so that when you're designing an IEP and things like that, that these children can get the supports across the board for all of these things and not just be overly language focused when there's other areas that need some supports and help as well.
One more question before we bring into the workshop. Working on the senior side of it. What success we did and why and going that I can help her and she art.
Yeah, that's a really good question. I mean, I guess I would say, does your child have seizures? Okay. So yeah, so I mean, once your child has seizures, I don't have a super lot of specific advice right now because we just don't know enough. So we need to have more, seizures are a rare kind of phenotype or rare symptom of a rare condition, right? So, like I said, most kids don't have seizures. And so you're talking about rare of rare. And so we just need more numbers to study and understand if there are specific types of seizures, specific therapies, and we could better answer that question. Right now, we don't have an answer. What I would say more broadly is, and again, if you've seen me in clinic, you've heard me say this, if your kid does not have seizures, there is nothing to do about it right now. If your KAT6 kiddo does not have seizures, please do not go get a bunch of screening EEGs for no reason. Please do not go, keep a monitor on your kid all night just in case one day they might have a seizure. Just go about your life. A lot of times you're not going to ever have a seizure. And if you see something that looks concerning, say something to your provider and go from there.
Okay. Family workshop, family counseling, family their benefit portal, and well, if you're signed up in group A,